You can tell that we've planned this. Okay, so my name's Laura Woods. I'm a nurse consultant in forensic healthcare in Sussex Partnership. I'm also a non-medical prescriber. I'm currently doing my AC training. So my area of kind of interest in terms of this was having worked in psychiatric intensive care unit for nearly 9 years. I'm kind of interested in the debate, actually, is whether what we do in PICU is specialist. Whether there are a specific set of skills needed to work in psychiatric intensive care. So the aim of kind of today's session really is just to consider, and it's much more about kind of reflection rather than coming up with any specific right or wrong, is PICU a specialist area of mental health? What do professionals working in PICU do? And if we are a specialism, can we maintain that specialism in today's modern healthcare? So just as a quick exercise, everybody stand up.
Gone off the spot.
No. That's the OT session if you want to go into some physical exercise. So sit down if you have worked in PICU for less than 1 year. Okay, sit down if you can see where we're going with this, it's not tricky. Sit down if you've worked in psychiatric intensive care for less than 2 years. Okay, so we carry on, so sit down if you've worked in psychiatric intensive care units for less than 3 years. Okay, those next, sit down if you've worked in less than 5 years in psychiatric intensive care. Getting to the core, aren't we? The meaty one there. Anybody still working in psychiatric intensive care after 6 years? How are you looking? You're a bit weathered, burnout, a few knobbly knees, a bit of arthritis. 7 years. Still working after 8 years in psychiatric intensive care. We really are the core bunch now, aren't we? 9 years still working. Okay, how many have we got left? We've got 1, 2, 3, 4, 12 of the audience still working. 11 years in PICU. 12 years. We're not going to carry on till row because it just would take all morning. We know these. Yeah. Okay, so if you look around, we've only got 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe 9 or 10 people that have worked in PICUs in this, group for longer than kind of 10 or 12 years. So I'm not saying that that's a good thing or a bad thing, but I'm talking about how does that experience and expertise get shared.
No, you can stand up for the rest of the talk.
Oh, no, you can sit down. Especially testing all your knees. So an interest of mine really is kind of going, how do we share those expertise? So if anybody knows Tom, who's doing a session later on this afternoon, we sat last night talking for quite a long time around kind of nurses working in PICU. And what is it that we do differently to our general adult colleagues, to our forensic colleagues? What is it that we possess in terms of skills? And how do we identify those and make those tangible, if there are any differences, actually? So NAPICU, in terms of our minimum standards, what we say is a good practice. A training programme for organisation and employee requirements should be available to all staff working on PICUs, yeah? And what we do say is that a specific training programme to cater for the specific clinical, interventional and skill development necessary to develop within a PICU setting. So are we able, as a group of professionals working in PICU, able to identify what those specific clinical, interventional and skill development necessary to work in PICU is? So one of the discussions we had informally, which is the best way to kind of network at conference, is have those informal discussions with people outside of these sessions and share practice. So one of the things that I'm interested in as a mental health nurse is how do we talk about, how do I engage with the patients that I work with and the core relationship. So one of the discussions which will happen later in terms of nurses becoming approved clinicians and nurses becoming non-medical prescribers, what is it that we do that is different to our medical colleagues, to our occupational colleagues? And I would argue that it's about the relationship, okay? And it's about the engagement that we have with people. So, I'm not going to waffle on for too long. So the professionals that we're going to hear from, Stephen is a consultant psychiatrist, Lucy is an occupational therapist, and Marianne is a clinical lead pharmacist. So what we want the session to be about is to think about whether it is a specialism, I'm waffling now, and whether we can maintain it. One of my areas that I want you to kind of think about as we go forward is how do we maintain a focus on clinical practice rather than process. So we've heard already this morning from James talking about we are obsessed with process. We are obsessed with policy, process. What is it, and we've had this kind of, so another area of my interest in terms of kind of the management that happens within the NHS and how that impacts patient care and the care delivery. So Stephen's going to talk a little bit about that, and then hopefully I'll come back in and we can have some discussion about that. So I'm going to probably hand over to you now. Yeah, is his slides already here?
Yeah, next one.
Is that you?
Yes. Next.
That's you.
Keep that, because you might need it to go.
Okay.
Yeah. Stay here. Right. So my name's Stephen Dye. I'm a psychiatrist, and for 17 years I worked on a psychiatric intensive care unit. I gave that up about a year ago, and being outside of it now has given me some time to reflect a little bit upon it. When I was within psychiatric intensive care, I was on the NAPICU exec, and I was quite heavily involved with it. I was being asked to speak, as has been said really, about medics and their roles on a psychiatric intensive care unit. Now, I'm not going to get you all to stand up. Well, I'm not going to get all of you to stand up. The most predominant professionals in there are going to be nursing staff. You can sit down, you can relax. Everybody else can stand up, please. Okay. All right. So about a third, probably, quarter to a third. Okay. Those of you who are doctors can sit down. Okay. OTs can sit down. No OTs. I'm gutted. Psychologists. Art therapists.
Who are you?
Physical activity needs. All right, now you've got to tell us who you are. Come on, then.
Social worker.
Yeah, okay, cool. Thank you.
Any pharmacists? Yay!
I deliberately left them off. Why can I do that? Okay, so most people are nurses, then doctors, and then lots of pharmacists. That's because you're here, I think.
No pressure.
Yeah, no pressure, yeah. Right, myself and a colleague, Andy Johnston. Andy, you in there? No, he's gone to the other session. He's probably out on the fag. So when we wrote a chapter about NDT working in psychiatric intensive care, we put it in the first book and it's revised in the second book. And this was one of the things that we came up with. It's a bit complicated. You only need to look at the top, really. So you have professional leads within a psychiatric intensive care unit team, and you have the team manager. The team manager is normally a nurse, therefore is a professional lead within that team for the nursing team. They interact. They all have kind of a shared vision about what the psychiatric intensive care unit should provide. What is psychiatric intensive care? I'll come back onto that towards the end. And underneath them, you're going to have obviously have a professional lead. And also you're going to have other people coming into the service, so you might have people coming in from, for example, social work perspective, and you'll probably be... what else are there? There's probably a thing. It doesn't look like this anymore, but this is what it did look like. I'm going to quote back to some of the stuff that you wrote. Third year, the first journal in the third year, not the first one in the first year. But what is psychiatric intensive care, and what's in a name? Well, in a quite provocative editorial, and read it if you haven't read it, and you will have access to it if you are NAPICU members. And you know, so basically, he was saying, well, psychiatric intensive care, is it any different? But then it is, because it's on a psychiatric intensive care unit. But is it just because it's a psychiatric intensive care unit that you provide psychiatric intensive care on it? Especially when other things that were developing around that time when he wrote it. There are lots of things coming in, crisis resolution teams, home treatment teams, all kind of doing the same type of stuff. It's you know, providing, as I put up there, really, a set of interventions aimed at acute disturbance and crisis. That's what we do in psychiatric intensive care, isn't it? Probably. Is it what they do on crisis intervention teams? Definitely. So within this editorial, he says that it appears that the consciousness of the clinical community within the UK understands psychiatric intensive care as a range of practice interventions enacted in a psychiatric intensive care unit. Yes, that's fine. But it is not difficult to advance a credible argument that psychiatric intensive care is much better defined as a set of interventions aimed at acute disturbance and crisis than it is as a place in which these interventions are to be.
So I have paranoid schizophrenia, high risk of violence, high risk of absconding, specifically hated women, so I thought women. We kind of carried out our EAP admission process, very much similar in the sense of we asked people like what they like to do, what their routines, roles are like in the home environment, and we kind of are able to establish specific goals. So I've got 3 goals here, which our team managed to establish. First one, patient's BMI was 52, so our goal was to increase physical activity, promote healthy balanced diet, that sort of thing. Goal number 2, patient's routine at home and on the acute ward, which she was admitted to us from, was empty. She didn't really do a lot, didn't want to engage with anyone, and so the goal from that was to establish interests and promote productive routine. Goal number 3, home environment was reported to be unlivable, and she wasn't taking care of her ADLs. She wasn't really looking after herself. So goal 3 was to promote and assess the patient's independent living skills. So this is where my first kind of OT conflict rose, because in my head, if you talk about like Maslow's hierarchy of needs, I know there's no OTs, but Maslow's hierarchy of needs, it would be, right, we need to assess the basics, let's get the lady washing, dressing, that kind of thing. However, it didn't quite work like that. We're based on the ward, as I said, 24/7. We had to find a way of building a rapport with this lady and trying to get her to engage in whatever we could. So that's where we came across dancing. I'm not going to say that dancing is the answer to every problem, but to this lady it did solve a lot for us. We set up a dance group. It came into our kind of overall activity agenda. So it'd be daily for an hour. We'd all go into one of our rooms and we'd just dance. The kind of emphasis that I wanted to put on that is when I would work in the OT department, and when I've kind of spoke to OTs about this, they kind of look at my goals and they look at what we needed to achieve with this lady and think, why are you dancing? You should be washing, you should be helping her with all these basic needs. But in order to just do something that she found fun and just do something that she enjoyed for that short period of time, led us to be able to do all the other things. We ended up taking on home visits, we sorted out her home, we referred her to trusts, we actually referred her to a community dancing group, so hopefully that solves a lot of problems in the future. She lost 2.5 stone in weight from dancing. And yeah, it really improved the way that she was on the ward, and we used it as in our care plans as Jean is, and I would get phone calls from wards when I was in the therapy department in the acute wards, and someone would say, could you engage this patient because they're bored? And I would cringe and want to just put the phone down and say, no way, that's not my job. I'm here to assess, I'm here to do very clinical, very straightforward work. But now, if someone's bored, the amount of assessment that I can get out of that, the amount of things that we can do, the amount of engagement, one-to-one time that we can have on the basis of someone wanting to do something that we can facilitate, it's brilliant. And I've got one of our colleagues to write, basically to summarise what the EAP team is. It's really good to hear it from other people as well. And they said, to summarise, the EAP team and the OT on the PICU provides intensive engagement and also facilitates a level of fun and enjoyment in an otherwise restricted environment.
Thanks, Laura. So, thank you, everyone. I'm the last up. So, my name is Marianne Van-De-Lisle. I'm the lead clinical pharmacist in NHS Lothian, and I work in the PICU unit that we have at the Royal Edinburgh Hospital. I've been working there for 9 years now, but working in mental health for 19. Ouch.
Whose slide's that?
Sorry. Oh, it's not mine. I think was it 19 years ago, Jonathan, you and I first met at the Royal Ed? It's been a while. So obviously my focus as a pharmacist, all on the medication. So my reflections have been asked to come and speak about this, and having worked both in rehab, adult rehab before, general adult services and in PICU. So what is the difference? What's different about it? What is it different? The patient group that we're treating, is that different in terms of medication and pharmacological intervention? I think actually no, because the patients that we see in PICU have got the same diagnosis as all our other patients in our adult wards. And when you look at the comorbidities that our patients have, we're just sitting there topping up. So of all the patients that we've treated in our PICU unit, so we opened a new purpose-built PICU in our new hospital in Edinburgh, August 2017. So it's 2 years we've been open, wow. But we've had patients through our doors with MS, with Huntington's, who've got comorbidities with HIV, we've got Hep C, we've got diabetes, we've got hypertension, we've got hypercholesterolemia, who've post-MI, who've, you name it, it's the whole gamut. So in terms of treatment for us then, we're looking at both the mental health and the physical health. And that's certainly, from my point of view, and perhaps all the pharmacists in the room would feel the same, that a lot of our contribution is actually to the overall health of the patient. It's ensuring that everything's treated. I mean, just in the last couple of months, in pre-screening done from the admission wards and then patients coming into PICU, gone back, checked through the bloods, picked up 2 pre-diabetic patients, one who then went on to start treatment while we were still in the PICU. So again, that's a part of the roles that we have as pharmacists. That's not necessarily any different to you would do in an adult ward, when patients are admitted either. So again, thinking, well, actually, what's different? What have I done as a pharmacist, or what's been my contribution in the actual specialism in PICU? So one of the things that I think, we're working with Jonathan a number of years ago, I can remember standing in the sort of dispensary room, in the room with the drug cupboards in it, a number of years ago. Heard the alarms go off. Oh, right, I'll maybe just stay here. One of my colleagues came flying in the door with the keys, with the start of a peeking of a black eye coming up there, having been whacked with one of the patients totally off guard. So the keys come out into the cupboard, right? get the meds out, 5 and 2, haloperidol, lorazepam, syringes, check, right, out the door. 5 minutes later, I'm still in the room. She can run back in again and drop the next lot of haloperidol, lorazepam. And I'm like, well, you've only just given it. Oh yeah, but we'll need another lot. And I've only got 25 minutes, so I need to get it ready. Well, why? Because, yes, there's been an incident, the patient's disturbed, staff are there trying to deal with it, but why do you need to prepare another one right now when you've only just given it? So, and then thinking back and reflecting on that, so at the time, because we saw, I know you put up the details of the innocent Pfizer work from 2013 around the different RT algorithms that were across the country and the breadth difference in those in terms of the drugs that were used, and also in the length of time in between monitoring, what monitoring was done, how frequently the monitoring was done. There was just absolutely no consensus in that at all. But at the time, ours was the standard, 5 and 2, give it after half an hour, and that was what happened. In reality, it didn't actually make any difference to the patient. It didn't really resolve that situation, and that was what just made me think, what have I been doing as a pharmacist all this time? When I've been reviewing and monitoring drug charts and intervening and giving advice on patient care and treatment, I just accepted that as absolute standard normal practice. So should it be? Should we be doing something different? I suppose this has all happened at the same time. There's been a lot of interest in that. Work done, papers published, and culminating in the BAP and NICU guidance from last year, which really great piece of research and evidence in terms of what should we be using, what is the evidence for treatment out there. And we changed our treatment algorithms. I'm sure many people did, or many trusts will have done. On the back of that, we now just have lorazepam as our first line IM. Interestingly, the audits that we've done in the year and a half since we've changed it hasn't revolutionised, has it? But there's been a shift in practice. We probably see about 50% of the time now it's benzodiazepine first, it's lorazepam first, before going down. And we do have haloperidol, promethazine, as the evidence was for. How much of that we're using, that certainly hasn't increased yet, but we changed. And we've been, I suppose, from that point of changing, we've been supporting staff with that, recognising that, certainly in PICUs, that it is different. The patient group in terms of disturbance and acute behavioural disturbance can be different. So we do need them to have that training, and as well as putting in the kind of change in practice in terms of the pharmacological treatment, put change in practice in terms of support for training in staff and de-escalation, and the work then. So on the back of that, from years ago, Jonathan and I, when Jonathan was last a jobbing nurse in a PICU unit, had a cup of coffee one afternoon and sat down to think, how do we improve things? We're using rapid tranq, we're giving PRN oral medication. Do we have any idea whether it does anything or not? So 2 cups of coffee later and some scribbling on the back of well, not quite a fag packet, but a bit of paper, we came up with a bundle using the Scottish Patient Safety Methodology, which you've perhaps seen or engaged with or seen before. And we turned that into how do we improve the monitoring and recording when we've used medication as required for acute behavioural disturbance. The initial baseline audits we did, it was only less than 25%, about 23% of all instances of administration in a acute behavioural disturbance setting was even recorded in the notes that had been given. Never mind whether it did anything, never mind whether the situation improved, whether the patient, it was resolved at the end of it. So having put in place, it was effectively just a really kind of simple sticker thing for the notes. We managed to improve recording and outcome measurement from rapid tranq in our unit over the years, up to 90% that we're now. And then using that in the ward rounds in the weekly review, actually going back and seeing, in terms of mapping it with disturbance or periods of disturbed behaviour, what was used, was de-escalation used, was medication used, did it make a difference? And from that, then being able to move away from that kind of standard, oh well, everybody just needs 5 and 2, to a tailored approach to, to managing that for patients. And I suppose as a pharmacist, one of the, Jonathan actually was speaking earlier about language and the use of language in the workplace and the units. And I suppose it's my absolute bugbear, and one thing that I'd like to think I'm managing to change in terms of culture around medication and the use of, is the fact that to IM and to AccuPhase are not actually verbs. And so I sound like a broken record, but it does raise a laugh from my colleagues when there's someone, perhaps a new member of the team, that comes in and uses that phrase, like, don't say that when Marianne's around. So really that's just my reflections really on pharmacy and the pharmacists. I think what I feel is perhaps the unique role that I've had as a pharmacist in PICU versus everything else. I mean, the whole range of every other stuff that you do as a pharmacist is in there, from medication reconciliation, medicine history taking, medicine reviews, monitoring of high-risk medicines, ensuring all the clozapine is done, all the clozapine monitoring is done, all the Lothian monitoring is done. And certainly one of the things that I've kind of been working with one of our consultants, our more recent PICU consultant, which I hadn't really thought about before, but quite like, is we've got a 3-step plan. So as a pharmacist, and I know when I'm coming into the ward round every week, she'll be looking at me to help her with the formulation of what our 3-step plan is. If current treatment doesn't work, what are we doing next, what are we doing next? So we have that for the longer term for patients, which is something that I've sort of never really worked with before in the adult wards. So just my reflection.